Good afternoon, students. So today I'm going to share with you the second part of our endocrine lecture series, and it's on adrenal endocrinology. And this lecture will focus on adrenal hyperfunction and multiple endocrine neoplasia. So the adrenal gland consists of a cortex and a medulla. The cortex is divided into three main layers: the zona glomerulosa, which is specialized into producing aldosterone mainly, the zona fasciculata, which mainly produces cortisol, and the zona reticularis, which also produces cortisol and androgens. The medulla typically produces epinephrine. Now, adrenal control, as we discussed in our previous lectures, is partly controlled by the hypothalamic pituitary adrenal axis through the CRH and ACTH, which eventually control the cortisol secretion. Cortisol gives negative feedback at the level of the pituitary and the hypothalamus to balance this axis into the normal state, where you would have ACTH level in the normal range and cortisol level in the normal range. I have to emphasize that baseline ACTH and baseline cortisol levels do not always tell us the full story of the patient's condition. A lot of the time we have normal ACTH values and slightly elevated cortisol, and the final workup would reveal ACTH dependent Cushing syndrome. And other times we might have low normal ACTH with low normal cortisol, and after ACTH stimulation test we find that the patient does not have a normal ACTH stimulation test. So I have to emphasize, especially after the LGD that we had today, that ACTH axis evaluation needs to be done carefully, and face values do not always tell the story or the full story. The second important point to remember is that ACTH does not control aldosterone axis. Therefore, patients with secondary adrenal insufficiency have intact aldosterone axis, which is not affected by the lack of ACTH. So how is the adrenal aldosterone control regulated? Well, mainly through the renin-angiotensin system. For example, here, starting from the bottom, if the blood pressure falls, renin is excreted, which converts angiotensinogen into angiotensin 1. Angiotensin 1 then gets converted into angiotensin 2 in the lungs under the influence of ACE, angiotensin converting enzyme. And angiotensin 2 stimulates the aldosterone production from the adrenal gland, which in turn retains salt and thus increases the the intravascular volume, and would lead eventually to a rise in blood pressure. Steroidogenesis is a complex process that takes place in the adrenal gland. If we start at the top with the cholesterol molecule, top left, you see that there is a cholesterol molecule. And then if you follow the cascade of events and enzymes in green, those are the main enzymes that we see in clinical practice, leading to condition that we call congenital adrenal hyperplasia. And we're going to talk about one hallmark or one typical example of congenital adrenal hyperplasia, which is due to 21-hydroxylase deficiency. The idea here is that the body, or the pituitary needs to have no detectable cortisol level in order to stop the ACTH production. This is a basic fact. The pituitary gland needs to feel adequate cortisol level in the serum in order to shut off excess ACTH production. What happens in these people with congenital adrenal hyperplasia is that they have an enzyme defect, whether complete enzyme deficiency or partial enzyme deficiency, that will lead to shortage in cortisol production. This shortage in cortisol production is not a nice thing for the pituitary. So the pituitary will work very hard producing more stimulatory signal to the adrenal gland in order to get the adequate cortisol that it wants. Now, that will happen so that with more ACTH stimulation to the adrenal gland, eventually more cortisol will be produced, which will satisfy the pituitary gland. But that comes at a cost. The more cortisol is generated under ACTH influence, there is shifting of this cascade that you see in front of you into production of other byproducts. Sometimes those byproducts are testosterone, sometimes those byproducts are other androgens, which usually lead to the manifestations that we see in different types of congenital adrenal hyperplasia. So that's the main idea behind CAH. Now, it depends on at which level this blockade is happening and the shunting of the overproduction of those hormones to which area they take us. So for example, here, if we have 21 hydroxylase deficiency, the shunting of the pathway will go the path of, if you look at the yellow part, progesterone, and then going down 17 alpha hydroxyprogesterone, and then keep going down androstenedione, and then keep going down testosterone. So you will end up with having a lot of testosterone as a consequence of very high stimulatory signal by high ACTH as an end result in congenital adrenal hyperplasia. So that's one of the endpoints. Okay, let's move forward. Now, hyperfunctioning adrenal gland, there are three main conditions that we focus on clinically. The first one is pheochromocytoma, the second one is Cushing syndrome, the third one is hyperaldosteronism. So let's talk about the first condition that causes hyperfunctioning adrenal or excess adrenal hormone production. So pheochromocytoma is a tumor arising from the adrenal medulla that secretes catecholamines or metanephrines, and it's rare in general, and it's estimated that only 1% of patients investigated for having pheochromocytoma end up having pheochromocytoma. Now, that is not to discourage us from investigating those patients who present with classic symptoms, but it's just an indication that those symptoms are not specific only for pheo, and they're common in other situations like panic attacks and other things. Pheochromocytoma has malignancy potential. It's malignant in 10% of patients, which means that in 90% of cases it's benign. Pheochromocytoma can be part of a familial syndrome, at least in 30% of cases. We have multiple endocrine neoplasia as an example, VHL as another example, or neurofibromatosis type 1. So all these syndromes have pheochromocytoma as part of those syndromes. You might read about the 10% rule, which also indicates that 10% of pheos happen in children, 10% of pheos are bilateral, that sort of thing. So these are true general statements. When we talk about bilateral pheochromocytoma, we do not mean that both adrenal glands now have to have pheochromocytoma. They can grow at different times or different time intervals. For example, somebody presenting with pheochromocytoma today, and then you treat him or you treat that patient with adrenalectomy on one side, that doesn't mean that he is not going to have another pheo in the contralateral adrenal gland, which was not resected 10 years down the line. So that's possible. So this is a picture of pheochromocytoma after resection. It's a dusky, dark type of tumor, and it's vascular. The presentation is mainly through the classic triad of headache, sweating, and hypertension. Keep in mind that hypertension could be sustained or paroxysmal, meaning that if you measure blood pressure of a patient today and you find it normal, that does not rule out pheochromocytoma, because we know that hypertension does not have to be sustained. It might be paroxysmal. People also have anxiety and panic attacks. They complain of weakness when they have the episode of catecholamine surge. Again, pheochromocytoma can be completely asymptomatic and only discovered by a screening of a hormonal screening of a patient who presents with an incidentally found adrenal mass. How do you investigate pheochromocytomas? The gold standard is doing the 24-hour urinary catecholamines and metanephrines, and plasma. So the 24-hour urinary catecholamines and metanephrines has to be at least 3 times above the upper limit of normal in order to be convincing for pheochromocytoma. Sometimes we see mild elevation in catecholamines and metanephrines, and that is an inconclusive test in general. We can also use plasma catecholamines. I typically use them in cases where I have when I would like to rule out pheochromocytoma rather than rule it in. It's a simple test and it has a very good negative predictive value. Now, some medications can also interfere with metanephrines and give you a false positive result, like tricyclic antidepressants. So you want to make sure that your patient is not on such medications. Chromogranin A is a marker that is positive in about 80% of patients with pheochromocytoma, but we don't clinically use it. It's not very helpful beyond the typical test that we do. Here is an example of a large adrenal mass pointed to by this blue arrow on the left-hand side, and you can see that there are areas of hemorrhage or necrosis in that big tumor, and in the axial cuts you can see it on the right-hand side, close to the liver. So the main modality of imaging, or the best modality for imaging of any adrenal mass, is to do abdominal CT, and we typically specify to the radiologist that we would like this abdominal CT to be done with and without contrast, following the adrenal protocol. One of the tests that is done for pheochromocytoma and paraganglioma is to do the MIBG scan. It's a mouthful of a name, meta-iodobenzylguanidine. It's a nuclear medicine test which shows up where the pheochromocytoma is. We don't usually do it to just diagnose pheochromocytoma. We're usually looking for metastatic lesions in some cases. So it's a good modality if you're looking for metastatic pheochromocytoma. So when to suspect pheochromocytoma? Again, it's a rare disorder or rare disease. So sometimes if you have hyperadrenergic spells, the classic ones, that might lead you to investigate for pheochromocytoma. Some patients might present to you with resistant hypertension or difficult to treat hypertension, and this should raise your suspicion for a secondary cause, including pheochromocytoma and other conditions like Cushing disease or acromegaly and so forth. It can happen in familial syndromes that we just mentioned that, like multiple endocrineoplasia type 2, neurofibromatosis type 1, and VHL. Some patients can present to you with family history of pheochromocytoma, and that would lead you to investigate the close family members, because it can be familial in up to 30% of cases. An incidentally discovered adrenal mass has to be worked up to rule out pheochromocytoma. That's the standard of care. Hypertension and new onset of atypical diabetes are 2 big red flags that should alert you to investigate for pheo. Interesting enough, we do get every once in a while referrals from anesthesia telling us that the patient was under anesthesia for another type of surgery, but the anesthesiologist had difficulty in controlling the blood pressure, or there was a lot of fluctuation in blood pressure in that patient. So they recommend that we investigate this patient for pheochromocytoma, because anesthetics can lead to a rise in catecholamines during surgery. Onset of hypertension at a young age, another red flag. Idiopathic dilated cardiomyopathy is another red flag. And history of gastric stromal tumors or pulmonary chondromas, which are known for Carney's triad. So how do you treat patients with pheochromocytoma? After you confirm the diagnosis and you localize it by imaging, the treatment of choice is surgical resection of that tumor, including the whole gland basically. So you remove the tumor and the whole adrenal gland on that side. However, before sending the patient to surgery, you have to control the blood pressure very well, because intraoperative manipulation of the tumor might lead to leakage of the hormone into the circulation, which would cause hypertensive crisis. So we have to control them with alpha blockers. The non-selective alpha blocker that we use is phenoxybenzamine, which is very effective in controlling blood pressure in general, and we up-titrate the dose to achieve good control of the blood pressure. If you don't have phenoxybenzamine, you can use prazosin, which is alpha-1 blocker, which is also very effective. If you still have hypertension, you can use beta blockers after adequate alpha blockade. Beta blockers should never be used in patients with pheochromocytoma before good alpha blockade. And why is that? We know that if we block alpha receptors, we decrease blood pressure. However, if we stimulate alpha receptors, we will have a rise in blood pressure. So if you give a drug which blocks beta receptors, you're shifting, or you're allowing the alpha receptor to be stimulated. They call it unopposed alpha stimulation, and that will lead to hypertension. So you always have to block alpha receptors first, and then you can add beta blockers if needed clinically. Now, calcium channel blockers can also be used for controlling blood pressure of patients with pheochromocytoma. However, it's not used, at least in our practice here. Alright, so treatment of pheochromocytoma is mainly surgical, and if there is metastasis, we also try to resect it surgically. I would like to apologize for the slide because it's in the wrong place and I cannot fix it, so I just want you to hear me out. Mitotane is not used for treatment of pheochromocytoma. It's used for treatment of adrenocortical carcinoma, which are two different things. We're going to talk about adrenal cancer in other part of this presentation or another presentation. So mitotane here is not appropriate for pheochromocytoma. It's used for adrenocortical carcinoma. Going back to pheo, again, the treatment mainly is surgical. If we cannot resect the tumor completely surgically, we use other forms of chemotherapy, systemic chemotherapy for pheochromocytoma. We can treat metastatic lesions by radiofrequency ablation. For example, metastatic lesions in the liver or other parts of the in the abdomen can be ablated by the use of radiofrequency ablation. Cushing syndrome is not part of pheochromocytoma, but we can see sometimes adrenocortical carcinoma, which is functional, and the functionality here is producing too much cortisol, and in that case you will have adrenocortical carcinoma, which is functional, causing Cushing syndrome, and that needs to be treated in the cases of adrenocortical carcinoma. Paragangliomas are neuroendocrine tumors arising from the extra-adrenal autonomic paraganglia, and they can be classified into sympathetic paragangliomas or parasympathetic paragangliomas. The sympathetic ones usually are abdominal, and they're functional and almost always secrete norepinephrine. Parasympathetic are usually located in the head and neck areas, and they're typically non-functional. So you will end up with a mass in the neck. The head and neck surgeon will resect it, and then pathologist will tell us that this is a paraganglioma. It did not manifest clinically because it's non-functional. Some paragangliomas can secrete dopamine, although that's very rare. So paragangliomas usually are sporadic but can be familial. The typical gene mutation is SDH gene. It's indistinguishable histologically from pheochromocytoma. So that's important to know, that histopathologically paragangliomas are very similar to pheochromocytomas. They do not secrete epinephrine because in order for the adrenal gland to secrete epinephrine, there is an enzyme that is only available in the medulla, which converts norepi into epi. When functional, the paragangliomas, symptoms of paragangliomas are very, very similar to those of pheochromocytoma, and the main treatment for paraganglioma is surgical resection. Now, there is a modality of treatment which is called MIBG treatment. you remembered the MIBG scan, which is a nuclear medicine investigation that we sometimes do. MIBG scan can be used for diagnosis to tell us where the metastasis is. And if the lesions are positive on the MIBG scan, we can utilize the same vehicle to deliver the radioactive material to ablate the tumor. So we can use MIBG as a diagnostic procedure or test, and we can use it also for therapeutic purposes. And we commonly use MIBG treatments for metastatic pheochromocytoma and metastatic paragangliomas. They're not used for primary lesions in the adrenal gland or before surgery of paraganglioma. So the next hormone that we're going to discuss is the aldosterone, and hyperaldosteronism is one of the secretory tumors in the adrenal gland. When should we suspect hyperaldosteronism? Mainly the combination of hypertension and hypokalemia should make us vigilant for such a diagnosis. Again, we receive a lot of referrals with adrenal incidentalomas, meaning adrenal tumors that were discovered incidentally without specific symptoms and signs, and we typically work them up if the patient had hypertension. We work them up for hyperaldosteronism if the patient was hypertensive. So causes of hyperaldosteronism include aldosterone-producing adenomas, which account for about 40% of cases with primary hyperaldosteronism. The other differential diagnosis, which is important, is bilateral adrenal hyperplasia, which is more common than aldosterone-producing adenoma. And it's a bilateral condition and is present in about 65% or so of cases of primary hyperaldosteronism. Other forms are, other causes of primary hyperaldosteronism are rare. Now, remember that we're talking about primary hyperaldosteronism because secondary hyperaldosteronism is an appropriate response in the body. For example, to hypovolemia. If you have somebody who has hypovolemia, the normal response is to produce a lot of aldosterone in order to raise the blood pressure. So that's what we call appropriate or secondary hyperaldosteronism. What we are concerned about in this lecture is primary hyperaldosteronism, which is due to a tumor or hyperplasia. So when we suspect hyperaldosteronism, we typically measure the aldosterone and renin ratios. And that test needs to be done in patients who are not on ACE inhibitors, angiotensin receptor blockers, or or spironolactone, which is the aldosterone receptor blocker. So you have to make sure that the patient is not on any of these medications before you do the screening test, which is aldosterone renin ratio. If the ratio was high, then you proceed to confirmatory test. Confirmatory tests include saline suppression tests or oral salt loading tests or other types of other types of confirmatory tests. Now, the idea is again utilizing physiology. If I bring a candidate and I give that person a salt load, I inject them with salt through the IV, or I ask them to take a lot of salt. The normal physiologic response is to shut down aldosterone production in the body. So if you measure aldosterone level after salt loading, you should expect it to be low. That's the normal physiologic response. However, in primary hyperpara, those tumors or the hyperplastic cells do not respond to normal physiologic cues. Therefore, you would have non-suppressible aldosteronism in such cases, which confirms the diagnosis of primary hyperaldosteronism. These are lists of some medications that affect the aldosterone renin ratio. I mentioned the most important ones. So once we suspect clinically that the patient has primary hyperaldosteronism by history, supported by physical examination, which is hypertension mainly, maybe some lower limb edema, supported by lab investigations, which include hypokalemia and elevated aldosterone renin ratio. supported by confirmatory tests, which shows non-suppressible aldosterone following a salt load. Then we go to localization. Localization is through imaging. The best modality is to do CT of the abdomen with and without contrast, and it's important to know that aldosterone-producing adenomas are typically small tumors that can be missed. So if a small adrenal mass was found in a patient younger than 40 years, with all the confirmation that I mentioned previously, then you can proceed with adrenalectomy. However, if you find an adrenal mass in older patients, because non-functioning adrenal masses are common in older people, then we have to revert to another study in order to confirm that this is the side which is producing too much aldosterone. Remember, adrenal hyperplasia causing hyperaldosteronism is more common than adrenal adenoma causing hyperaldosteronism, and adrenal hyperplasia is a bilateral condition. So how do we distinguish bilateral adrenal hyperplasia as a cause of primary hyperaldosteronism versus a unilateral adrenal mass causing this hyperaldosteronism? Well, we have an invasive test which is called adrenal venous sampling. The invasive radiologist will insert catheters into both adrenal veins, the right and the left, and the radiologist will take blood samples so that we can measure aldosterone levels, and we compare the right and left aldosterone levels. If it's higher on the right side, for example, and suppressed on the left side, this confirms that I'm dealing with a unilateral adrenal adenoma causing hyperaldosteronism. If I get bilateral equal levels of aldosterone, then I'm dealing with bilateral adrenal hyperplasia. It's very important to make that distinction, because if I find a unilateral disease, I can resect that adrenal gland and cure the patient. But if I find that the patient has bilateral disease, which is the hyperplasia, we do not do bilateral adrenalectomy. We elect to treat those patients with medication only. The medication is the aldosterone receptor blocker. So just to read the slide, treatment of bilateral hyperaldosteronism, treatment of bilateral adrenal hyperplasia, which is producing too much aldosterone, or if the patient does not want to undergo surgery, we can use aldosterone receptor blocker, which is spironolactone. However, if we find that the disease is unilateral, either in a young patient, less than 35 or 40 years of age, or if we did the adrenal venous sampling and we confirm that it's unilateral, we can offer the patient adrenalectomy, and that will cure the patient. What should the patient expect post-operatively? Hypokalemia will improve in all patients, and hypertension will improve in the majority of patients, meaning if they were on 3 drugs, they might just require 1 drug to control their blood pressure. Sometimes we get lucky and the patient would not require any antihypertensive medications. Again, that depends also on the age, because essential hypertension is also common as we age. So the hypertension that the patient would be suffering from might not be only due to primary hyperaldosteronism. It could be also, there's a component of essential hypertension which will not resolve by adrenalectomy. The third common problem is Cushing's syndrome, too much production of cortisol, and we discussed this briefly. If you have a patient presenting to you with symptoms suggestive of Cushing's syndrome, clinical findings suggestive of Cushing's syndrome, and positive screening test that we discussed previously, with completely suppressed ACTH level in the absence of intake of any steroids, then you have a diagnosis of adrenal Cushing. So again, you have to have symptoms, signs, screening tests, positivity, and low ACTH level. Now, low ACTH level will tell you that it's either adrenal or exogenous, meaning the patient is taking exogenous steroids, whether orally or intra-articularly or any form of steroids. If you rule that out, then you have a diagnosis of adrenal Cushing. Then you move on to anatomic localization by doing the adrenal CT, which shows a tumor. And if you confirm that on imaging, you can send the patient right away to have surgery. Cushing syndrome, due to adrenal masses, is usually the tumor size is much bigger than primary aldosteronism. The arrow here points to an adrenal mass in a patient who has Cushing syndrome. ACTH independent Cushing syndrome. So the mainstay of treatment is adrenalectomy, and you will need, as we said before, you will need to replace the patient or to treat the patient with high dose of steroids post adrenalectomy until their HPA axis recovers spontaneously. In cases where surgery is not possible, or there's cancerous Cushing syndrome, like a cancerous adrenal mass that is metastatic, what can we do to these people? We use ketoconazole, which decreases the level of cortisol because it decreases synthesis of adrenal steroids. We can use metyrapone. We can use cortisol receptor blocker like mifepristone, and in cases of adrenal cancer, not adrenal adenomas, adrenal cancer, we use mitotane. Let's switch gears and talk about multiple endocrine neoplasia. Multiple endocrine neoplasia is a broad term that includes several syndromes featuring tumors of endocrine glands, and those tumors can be malignant or benign. The three main classifications are multiple endocrine neoplasia type 1, and we have type 2A, and we have type 2B. So you can see here at the figure in blue on the left side, MEN1 includes pituitary adenoma, parathyroid hyperplasia causing hypercalcemia, and pancreatic tumor. The pituitary adenomas could be anything, secretory or non-secretory adenomas. The pancreatic tumors could be anything, functional or non-functional. If they were functional, they might produce too much glucagon, they might produce too much insulin, depending on the situation. MEN2A, in red, you have parathyroid hyperplasia, which will lead to hypercalcemia, and you have medullary thyroid cancer, and you have pheochromocytoma. MEN2B, you have mucosal neuromas, marfanoid body habitus, medullary thyroid cancer, and pheochromocytoma. Now, VHL, neurofibromatosis type 1, Carney complex, McCune-Albright syndrome, these are all other types of syndromes that may include some tumors in the endocrine system, but they're not called multiple endocrine neoplasia. So let's start with MEN1. So it's a heritable syndrome, predisposition to tumors in the parathyroid gland, anterior pituitary, and pancreatic islet cells. They're rare, one in or two cases in 100,000. There's a mistake here in the slide, in 100,000 people. How do you clinically define them? You have to have 2 out of 3 glands affected in patients with no family history of MEN1, or 1 out of 3 glands affected in a patient with positive family history for MEN1. For example, if I have a patient who has a brother with MEN1, and that patient presents to me with hyperparathyroidism and hypercalcemia, then I can classify him as a case of MEN1 as well, because he came with 1 gland disorder with family history of MEN1. Most common component is primary hyperparathyroidism, and it occurs in almost all patients beyond the age of 50. Here is the percentage of the manifestations of these patients. So primary hyperparathyroidism occurs in more than 90% of patients. It should be more than 100% of patients, but this study probably included younger patients who are less than 50, so they still did not manifest the primary hyperparathyroidism. Pituitary tumors are found in 10 to 20% of patients. They can be prolactinomas, growth hormone secreting tumors, corticotropin secreting, which is ACTH, or non-functional. The third component is the enteropancreatic tumors, which account for 60 to 70% of tumors. Could be gastrinoma, insulinoma, VIP, glucagonoma, PPP, which is pancreatic polypeptide secreting, or non-functional. So the genetics of MEN1, typically autosomal dominant inheritance. 75% of cases are related to MEN1 gene mutation. There are other gene mutations involved here, but that's the most common one. It's a tumor suppressor gene and produces the protein menin. Families with the same type of mutation do not necessarily have the same clinical phenotype. Example, index case has prolactinoma, primary hyperparathyroidism, and non-functional pancreatic tumor. Brother of that patient might have non-functional pituitary adenoma and maybe gastrinoma in the pancreas. Okay, so they don't manifest the same phenotype necessarily. So parathyroid tumors almost found in all patients with MEN1 by age of 50. They present with primary hyperparathyroidism. So what's the difference between MEN1 hyperparathyroidism and sporadic non-familial hyperparathyroidism? MEN1, more than one gland is affected, more than one parathyroid gland. How many parathyroid glands do we have? We have 4. So typically in MEN1 we have more than one gland affected. In sporadic primary hyperparathyroidism we have typically one adenoma. Male to female ratio in MEN1 is equal, while in sporadic more in females. So more patients present with non-familial primary hyperpara. The third point is that MEN1 present at a younger age with primary hyperpara compared to older age presentation in sporadic primary hyperparathyroidism. Now, because the primary hyperpara affects more than one gland usually, the surgical treatment is different from the primary hyperpara in non-familial cases. We're going to talk about this later. So MEN1 is found in 1 to 18% of patients who come with primary hyperparathyroidism. So parathyroid tumors, the majority are asymptomatic. If symptomatic, they have polyuria, polydipsia, constipation, kidney stones, low bone mineral density. This is because of hypercalcemia and hyperparathyroidism. So this is a schematic that shows the difference between parathyroid adenoma and primary parathyroid hyperplasia. The adenoma is non-familial. The primary parathyroid hyperplasia at the bottom is familial, which we see in MEN1 typically. They have the classic symptoms of constipation. What else? Joint aches and pains, and depression or mood changes. How do you investigate those people? They have high calcium and they have high PTH levels, and then you try to localize the tumor, whether it's we utilize ultrasound of the neck and another test which is called system scan, which is a nuclear medicine test to locate the tumor site. And okay, so pancreatic gastrointestinal adenomas are the second component of MEN1. Those are more serious among the 3 manifestations of MEN1 because they have more malignant potential. They're found in 1/3 of patients with MEN1, or maybe a bit more actually. Malignancy potential is high, even if not functional. The types of pancreatic tumors include gastrinomas, insulinomas, vasoactive intestinal peptidomas, or glucagonomas, and each one has its own different presentation or symptomatology, as you can read here in this slide. So this is an example of glucagonoma with this typical facial rash. The picture at the bottom right, somebody presents with anxiety, sweating, hunger, confusion. What do you think is the type of tumor in their pancreas? It's most likely insulinoma. And this is a picture showing severe dehydration in a patient with this skin turgor that you can see. And that's typically seen in vipomas because they have very, very bad secretory diarrhea. طبعا the picture at the top right is gastronoma because they have what we call Zollinger-Ellison syndrome because of gastronoma, so peptic ulcer disease, severe ulcer disease. The third component of MEN1 are pituitary tumors. We're not going to delve into too many details, but they can be secretory or non-secretory. They're usually present at 15 to 25%, and they have similar features to those that are sporadic pituitary adenomas. So this is an example of a patient with MEN1, and what do you think? Acromegaly. And here, what do we see? We see bitemporal hemianopia because it's a macroadenoma most likely. So expression of MEN1 with the estimated penetrance, this is just a repetition really. So MEN1 treatment depends on, so primary hyperparathyroidism, surgery is indicated, surgery indications are similar to that of primary hyperpara, the typical primary hyperpara, non-familial. But they have severe hypercalcemia, renal stones, low bone mineral density, and I don't know what this is. Also, severe ZES can improve if concomitant primary hyperpara was treated. Not sure what this is. Don't worry about it. So surgically, typically is 3.5 glands removed. So the surgeon will open the neck, try to locate all 4 parathyroid glands, and will resect 3.5 of those glands. So the patient will remain with only half a parathyroid gland in their neck. Despite that, the relapse rate is high, meaning that this left behind half a gland might continue to grow over time and might cause primary hyperparathyroidism 10 years down the line or so. And then the patient will need to undergo another surgery. Why don't we resect all 4 glands? It's a good question, because the patient without parathyroid hormone will need loads and loads of calcium and calcitriol, which is active vitamin D, in order to maintain their serum calcium. So parathyroid hormone is very, very important for us to maintain serum calcium. So we cannot resect all 4 glands, but we just leave behind a small portion of the parathyroid tissue. How do you treat pancreatic and GI tumors? Also by resection. Okay, I think ZES is Zollinger-Ellison syndrome. So medical therapy might suffice in Zollinger-Ellison syndrome. Otherwise, duodenectomy and ultrasound-guided pancreatectomy can be done. Pituitary tumors are treated the classic way that we discussed in our previous lectures. If it's a prolactinoma, we start with medical therapy. If it's other types of tumors, secretory tumors, we offer them surgery. If it's a non-functional pituitary tumor, we will evaluate for the need of surgery versus no surgery and observation. Now, the problem is handling metastatic multiple endocrine neoplasia patients. We can utilize embolization therapy, radiolabeled therapy, radiofrequency ablation therapy to metastatic sites, or somatostatin analogs, which are also useful in controlling functionality of these tumors. Meaning, if somebody has VIPoma with secretory diarrhea and that sort of thing, they might respond to somatostatin analogs like octreotide therapy to decrease the secretion of that non-resectable tumor. Moving on to multiple endocrine neoplasia type 2. It's autosomal dominant, mainly driven by RET oncogene. It's very important to remember that gene. So mutations in RET oncogene are responsible for this disorder. 100% of patients will develop medullary thyroid cancer. 50% will develop pheochromocytoma, and 30% will develop hyperparathyroidism. Those are the three main aspects of multiple endocrine neoplasia type 2. Now, the difference between 2A and 2B is shown in this table. So medullary thyroid cancer occurs in 100% of patients with MEN2A or MEN2B. However, it's very important to remember that 75% of cases of MTC, medullary thyroid cancer, are sporadic. So this means if you see somebody in the clinic and the only thing you know is that they have medullary thyroid cancer, what is the chance of this being part of multiple endocrine neoplasia 2? The chance is about 25%. So it's much more likely that this medullary thyroid cancer is sporadic, non-familial, meaning those patients will have negative RET oncogene mutation. The familial is associated with RET oncogene mutation. Those tumors originate from C cells, not follicular cells. So the tumors that arise from follicular cells include papillary thyroid cancer and follicular thyroid cancer. Here we are talking about medullary thyroid cancer. And they're also associated with high calcitonin and high CEA. CEA is a abbreviation for carcinoembryonic antigen. Those two, this calcitonin and CEA, are tumor markers. So if we resect or if we remove the medullary thyroid cancer, we can utilize the calcitonin and the CEA levels to monitor tumor recurrence. Now, how do you diagnose medullary thyroid cancer? Typically, the patient will present with a thyroid nodule, or maybe you will do an ultrasound looking for it, and you will find thyroid nodules. And if you do an FNA, it will show that it has medullary thyroid cancer. So any patient with medullary thyroid cancer presenting to us in the clinic must have RET oncogene mutation analysis to determine if it's sporadic or familial. If the patient has positive RET oncogene, we ask the patient to bring all his immediate family members, and we do this mutation on all family members. Those family members with positive RET oncogene will have medullary thyroid cancer 100%. So the penetrance is 100%. So we can offer these family members prophylactic thyroidectomy in order to prevent the occurrence of medullary thyroid cancer for life. This is very, very important, and we practice this in our daily practice, basically. Type MEN2A, pheochromocytoma needs surgery, as we discussed before. Primary hyperparathyroidism needs parathyroidectomy, 3.5, as we discussed before. MEN2B includes medullary thyroid cancer and pheochromocytoma and marfanoid features, as you can see in the graph of that young boy on the right hand side. And also here, which is interesting, you see a big neck scar. What do you think this scar is for? Well, obviously this is for thyroidectomy and bilateral bilateral lymph node dissection, because this patient also has medullary thyroid cancer. So marfanoid features, mucosal neuromas, as you can see in the those two tongues of young people, maybe, or the bottom one is a young person and the top one is an older person. They also have intestinal ganglion neuromas. So in summary, MEN1, you have MEN1 mutation. MEN2A and MEN2B, you have RET oncogene mutation, and those are the features of the two arms of this syndrome.